have got awards. She has received gold medals while doing her diploma in nursing administrations from the IGNO in the year 2015, and she has a working experience of total 15 years only in a pediatric department. So thank you, sisters, for accepting our invitations and willing to take the class today. And we have our next guest speakers, Longjan Kamala Devi ma'am. I think in first class also we have given the introductions, but especially this is for new staff, new participants, those who have not do not know our ma'am. So ma'am is working as a lecturer in College of Nursing, Anigrim, Shillong, Meghalaya. Ma'am has done a BSc Nursing from Sri Narayana Nursing College, Nellore AP, and passed out in the year 2011. And she has done a master's in OBG from Bolini College of Nursing, Nellore AP, and passed out in the year 2015. She has a total 9 years of experience and 1 year of experience in clinical. Rest 8 years, she has done. She has worked in a teaching area. During her career time, she has published 5 journals, and independently, she has done 2 research projects. She is member of various of associations, TNI, Nursing Teacher Associations of India. Even she is a member of Society of Midwives India and Glorious International Nursing Research Academic. So we are happy to have you, ma'am, today as a guest speaker. So as usual, first we will do our presentations. Once we will do the presentations, then I'll give some time for our guest speaker to speak, and after that we will have a discussion time. So here we are lucky to have 1,000 participants in one platform. So anyway, we are doing a presentation from our side, but I request participants to share their experience and speak up about what you are doing and how you are doing and what are the challenges you are facing in your ground level, so that at least if others are also facing and if they have better solutions, then they will help you. These sessions is not only sitting here and teaching to you. We don't want a one-way kind of communications, but it will be great if some kind of experience we also get to know from you all. So I highly encourage all the participants to actively participate, especially during the discussion time. Sorry, during this time also I'll not give access to talk, because the situations. So that's why. So without much delay, now I'll request our presenter, Madam Sunita, for the presentations. Over to you. It will be distinct.
Very good afternoon to everyone presented here, and my respected Nanuka madam, who is arranging this pediatric respiratory pediatric programs, and our Longjam Devi ma'am, who is co-host today. And thank you for being here today. Then now I'm going to discuss my topic today: pediatric respiratory therapy, oxygen therapy, different methods including NRBM, use of MDI, and spacer. Before going to discuss this topic, here I want to say then what are the disease conditions? We have to know what are the disease conditions and what are the clinical condition deterioration. How we'll find out those cases when we'll give respiratory therapy and oxygen therapy. And here I'm going to I'm going to discuss about definition. What is the definition? Like respiratory therapy, what definition? Respiratory therapy is exercise and treatment that helps to improve and restore lung function. Those cases who are having lung deterioration, restored lung function due to various disease conditions, in those cases, we are going to give respiratory therapy. The aim of respiratory therapy to improve breathing mechanics. Once the airway is blocked, air or lung function is jeopardized. They are due to various disease conditions. Airway might be blocked. There may be secretions. There are some accidental condition. There are some chronic illness. Lung function might be jeopardized, and in this case, we aim to give respiratory therapy. Then here I want to talk about respiratory diseases. I think anybody have Those who have knowledge about respiratory disease can give in the chat box what type of respiratory disease we are going to give respiratory care.
You can write down in the chat box what are the different kind of respiratory disease where you will give the respiratory therapy. You can write down in the chat box. Yeah, COVID, they have mentioned the COVID, pneumonia, OPD, tuberculosis, SARS,
Yes.
Pneumonia, ARDS, COPD, asthma, okay.
Okay, it means lots of knowledge. Everyone knows actually, but thing is that only other causes like in pediatric, like newborn babies and all, be different, and how we'll find out like transient tachypnea and all, we have to know. Then here I'm going to discuss like lower respiratory tract infection, severe pneumonia, both COVID and other pneumonias, and bronchiolitis, inflammation of bronchioles, and upper airway obstruction may be due to various causes, thick secretion like pneumonia and all, severe asthma, those like inflammation of bronchioles, patient most have inflammatory asthmatic condition. Then common neonatal condition like birth asphyxia, respiratory distress syndrome. Those who are having birth asphyxia immediately after birth and RDS, they are needed in they are also a part of respiratory disease. And severe sepsis, some patients develop early onset of sepsis and some develop late onset of sepsis also. Then cardiac condition like heart failure and shock, and cardiopulmonary arrest. I think got the points. Then what are the respiratory therapy procedures? Those patients, some patients and only minimum problems. They are having minimum respiratory distress. They are having like they can manage by medication. Some are going aerosol therapy. I think many have knowledge about aerosol therapy. Like we are giving nebulization. And airway management also another important thing. If airway is blocked, we have to do suctioning, we have to do chest physiotherapy to drain the secretion, and oxygen administration. Those patients who are having less oxygenation, like SpO2 is low, who are having central cyanosis, those are needed immediate oxygenation. And chest physiotherapy also a part of respiratory therapy. Chest physiotherapy we are going to discuss in detail. Then lung expansion therapy also we are going to discuss in detail, and pulmonary rehabilitation. There are some hospitals, they have pulmonary rehabilitation centers. And in these cases, the patient will get both physical and psychological support. And those cases, we are not maintaining after medication, aerosol, after airway management also not able to manage. Those patients need mechanical ventilation, means we have to put with endotracheal intubation and put on ventilation. And suction for removal of secretion of lung, that is very important. Then here I'm going to discuss about aerosol therapy. I think majority of what medication we are giving in aerosol therapy, you can mention in chat box also.
Yes. You can write down in the chat box. Livolin, Esteline, we have mentioned. Esteline.
Yes, very good. Yeah.
Esteline, yes. Yes.
Yes, that is even our hospital setting also we are giving like Asthalin, adrenaline, Livolin, and this one, like sometimes we give adrenaline also, and in some cases we are giving only if NS also, it will liquefy the thick secretion. And what is aerotherapy? The process of dispersing a liquid. That means we are giving the medication into a microscopic particle. This is a nebulization chamber. Here, every hospital facilities they are using, and delivering into the lungs. Here will connect the oxygen pipe with the oxygen pipe. Oxygen will generate this one air, and it will fume will be there, and it will go to the lungs. The patient inhales through the nebulizer. It is used to liquefy and remove retained secretions from the respiratory tract. That is, after that, if we give nebulization, after that, if we continue physiotherapy, then secretion will be drained to the trachea. Then we have to do suctioning after that, after nebulization, so that the thick secretion will not remain in the trachea. If we do suction properly, then it will not go back again to the trachea. Is it very fast?
No.
It's okay. Then chest physiotherapy, the very important point, those who are chronic lung disease cases, those who are having lung atelectasis, maybe their alveolar is collapsed, those patients are needed chest physiotherapy. Then what is postural drainage? I think people have idea about postural drainage. Now we are positioning the patient. Here I'm discussing about everything about only practical aspects, what we are doing in our facilities when patients are coming. Then postural drainage. What is postural drainage? When postural drainage will drain the thick secretion, will try to drain to the from bronchus or bronchioles to the trachea. We'll give a position. We'll show different positions. We are showing later on one position, different positions, so that it will drain. Will suppose the patient is having upper side lung, this one having thick secretion, then we'll put that side up and it will drain to the trachea and we'll do suction or physiotherapy. Then later on, this we are doing percussion and vibration is in combination. We do different type of percussion vibration is there. I'll talk here. Chest physiotherapy should be followed by reproductive cupping and suctioning of the patient. Chest physiotherapy should never be done straight after meal or drink. That is very important. Even in case of nebulization also, we should be very careful that we should not do nebulization just after meal or drink. Even same case here, in case of physiotherapy also, we should be very careful so that we won't give that physiotherapy immediate after our meal or drink. Patient might have vomiting, patient have regurgitation, they will feel discomfort in the abdomen. And there are different type of devices also now, some like electronic device also there to give chest physiotherapy. So it will give vibration and percussion. But in children, most of the cases we are doing CPT for newborn. This is very important for newborn. We cannot give hand or some vibration by instruments. And that's why very important for newborn. We are using here is a embu bag mask. This coming with embu. Sometimes we can use other device also smaller, so that we'll hold nicely with our hand and we'll give slap in this one ribs, lower side of the ribs, so that we won't give in the middle of our ribs, so that it has high chance of breaking. And we'll give stepping in the this one chest of this one lower side of the ribs. Then for older children, when this is the method how we are giving here, it is very important that we will hold our fingers and this is thumb will hold airtight, so that there will be proper percussion and vibration sound will be there while we'll clap in the back of the chest or this one ribs. That's why we have to be very careful while giving this one. And it will, after that also, proper positioning of the patient is very important, so that it will drain to the lungs, from the lungs to the trachea. Here is the picture of postural drainage, how we make position of a patient in case of mucus in the airway, so that it may cough out. Suppose here is the thick mucus is there. We are giving here tapping, and we are putting the position so that thick secretion will drain to the trachea. Tapping is performed in certain areas with the patient in different positions, and we can use different positions. Suppose other side also is there, we have to use different position accordingly. Then lung expansion therapy, very important in case of patients who are having lung collapse, those who are having atelectasis. I think everyone knows about atelectasis. Here, atelectasis means it will reduce air in this one, alveolar. Then alveolar will be collapsed. In that case, variety of respiratory are designed to prevent cardiac atelectasis. What we will do in these cases when patient is having atelectasis, especially in newborn babies, like those who are newly respiratory distress syndrome patients, very prone to get this one atelectasis. They are having less matured heart muscles and lung muscles, so respiratory muscle also not matured. That's why those patients will have prone to get atelectasis. In that cases, what common modalities we are using? Except newborn babies, mostly we cannot use Incentivesspirometry. In that case, we either go to CPAP or some other procedures. For older cases, we can do Incentivesspirometry. In that case, we are going to talk in detail about Incentivesspirometry. Then CPAP, continuous positive airway pressure. That one, either bubble CPAP or sometimes we connect CPAP in ventilator also. another classes also there is about CPAP and this one ventilation. They will talk detail. Then intermittent positive pressure breathing, another type of lung expansion therapy. Here I want to, I think majority of us has used even in peripheries also they use Incentivesspirometry. How many of use the Incentivesspirometry? Can raise hand, I think.
You can either.
Any idea about Incentivesspirometry?
Okay, the Manik has said. Anyone of you who are using
and those who are not using also can say,
yes,
so that they will feel nice to talk about this thing.
Yeah, I saw 2 hand raised. Those who are using, you can write in chat box yes or no also. Yes, many of you are writing yes, many of them are writing no. Yes, hand raised. Okay, okay. I see many hand raised. Okay, that means many of you are using spirometry. Okay.
Here only that how properly, if we are using something that should be proper way of using that. Here I'm going to the what is Incentivesspirometry used for preventive and prophylactic treatment to achieve maximum inspiration, then to prevent lung collapse, to prevent alveolar collapse, so that it will give lung expansion. Then instruct the patient to hold spirometry upright, exhale normally. Before inhalation, they have to exhale normally and completely through mouth place in the lip tightly around the mouthpiece. Ask to take slow deep breath, maintain constant flow. After exhaling normally, we have to ask the patient to take slow deep breath through the mouthpiece of this one and maintain constant flow so that the bowl here will be raised up to the level of that patient need. Up to the level of the patient need. Doctor, usually pulmonologists will prescribe how much this one, they will teach to them also how much this ball have to raise, and we have to observe is it they are doing properly or not. Then schedule of 10 attempts every hour. Means in every hour, if patient stand sitting position so that they can do comfortably 10 attempts every hour. Then what are the 2 different types of like Incentivesspirometry? That is Incentivesspirometry like volume oriented and flow oriented. Here I am showing this is flow oriented, that it will be liter in 5 liters, 6 liters like that, this one. And there are some other device like flow oriented. Here it will be written 500 ml, 1000 ml, 1500, 2000 like that. It will be volume oriented. And in that case, when we will inspire, there will be piston will be raised to that desired level. I think, okay. Then CPAP, continuous positive airway pressure. The common purpose of all this technique is to guide the patient to improve pulmonary function by maximizing alveolar equipment and optimizing airway clearance. Airway clearance also very important. And if any secretion is coming, we have to do suctioning it. Then intermittent positive pressure breathing. What is intermittent? This technique cannot be used those who have not facilities like machinery, ventilation and all. It provides short-term or long-term intermittent mechanical ventilation via mouthpiece to or mask for lung expansion and delivering aerosol medication like nebulization we can give. And supportive measure is very important thing. We are giving oxygen, we are giving physiotherapy, but we are just doing normally. That does not mean we have to give a supportive measure. We have to give comfort to the patient. We have to give assurance to the patient. We have to give teaching to the patient. And more than that, we have to give the patient proper bed rest. Then positioning of the patient is very important according to need of the, suppose patient need upright position, we have to put upright, right? And warmth of the room. Suppose patient is very cold, they are not having proper clothes, we should ask them to give proper warming. Then isolation, those patients who are in very infected cases, we need to be isolated like those TB and all. And suctioning, already talked, adequate fluid and dietary intake. This is very important when patient is like very in shock condition. And this one, we have to find out the deviation on how to find out shock and all. Sometimes doctor will not be there. We have to tell them that patient may need of fluid intake, patient may need of high calorie intake. Then another thing is humid environment, also very important thing that room should be humid. Then hygienic measures, we have to teach them how to take the hygienic measures for proper cleaning, proper eating, and postural drainage, as I have talked already, proper positioning of the patient to drain the secretions from the lungs. Then chest physiotherapy and treatment of complication according to the relevant other complication also we have to treat. Patient might have fever, patient might have dehydration, we have to treat all those things. Then oxygen level. Actually, we are going to give respiratory care, we are going to oxygen therapy. Before that, we have to know how to find out this one, how to find out what type of distress, how patient is in distress or not, whether patient is in need of oxygen or not. Then here I'm going to talk in the first class, I think in vital sign, there was one topic like physical assessment and vital signs there is talked very nicely. The normal vital signs, at least we have to know, because pediatric is bit respiration and heart rate, pediatric is bit higher comparing to adult patient. That's why we have to know what are the normal ranges of vital signs, so that we can compare, and we can compare the baseline also to treat the patient whether the patient is in need of oxygen or not. Moreover, clinical sign and symptom. Suppose this patient is very having chest retraction, stridor, then upper airway, this one respiratory sound, sometimes wheezing sounds from the lower airway, all those things also, even sometimes retraction will be there. Some in that case, grunting also there. In those cases, we have to find out without doctor also. Sometimes we have to go and start oxygen. Sometimes doctor will be very late, half an hour. It will take time to reach. They will till the time they observe. We have to by clinically also. Even when there is no oxygen supply, we can or when there is no SpO2 monitor, we can give oxygen supply to the patient. Here we are going. What is oxygen level? How we will know that bound oxygen, that the ratio between hemoglobin carrying oxygen and total hemoglobin is called bound oxygen. What is SpO2? The measured as SpO2 non-invasive by pulse oximeter means when we are doing with a pulse oximeter, that means it is non-invasive. We are not pricking to the patient. We are not giving anything. That is non-invasive. That is very easy to measure. And invasive by arterial blood gas. That means we are going to prick to the patient. We have to take the blood. We have to do analysis. That is a bit difficult when ICU setting we are doing. But in those cases who are working in periphery, it will be difficult for them to do arterial blood gas. So it is easy only SpO2 monitoring, and by clinical observation like heart rate, how is the heart rate, how is the pulse rate, how is the respiration. From that also we can find out whether patient is in need of oxygen or not. Here yesterday class, some people they are asking about SpO2 is showing normal. A patient is SpO2 is showing normal, but patient is like cyanosis something. Then here I want to show about this one. In this case, this is very normal SpO2 reading, and this is not normal. Why? We can read this one from the graph. Here is the graph is evenly. Here is the graph. When our heart will contract, this one, this graph will go up and gradually it will slow down, and it is evenly distributed. It is this one space also equally, and wave also like equal wave is there. That means this is a correct reading. Here you can show, see this one, this is not a correct reading. Here graph is not evenly, not equal, even not evenly distributed, and amplitude also different. In this case, there may be various reasons of this thing. Maybe this one, our peripheries are very cold. Maybe something is there in that probe. Maybe we are not placing properly. That's why this thing we have to observe. Sometimes this is how to read the graph is very important. Most of the people actually they never look at the graph. They will just look to this monitor, and they will be surprised whether it is very high or low. That's why very important to know this thing. Then purpose of oxygen therapy. What are the purpose of oxygen therapy? To increase awareness for improving the availability of oxygen, improve the detection and management of hypoxemia in severely ill children, improve the delivery and monitoring of patient on oxygen therapy. Then Here I want to talk very important for detection of cases whether in need of oxygen or not. What the word hypoxemia and hypoxia. Hypoxemia means low level of oxygen in the blood. Low blood oxygen saturation or content means patient is having low level of oxygen in the blood. But this one will gradually develop to hypoxia. That is, hypoxia is inadequate oxygen in tissues for normal cell and organ function, and hypoxia results from hypoxemia. And this thing, suppose hypoxia is a tissue is not getting adequate oxygen, then organ function will, because oxygen is helping to tissue metabolism and using of this one and energy building in our body tissues. That's why very important to detect the hypoxemia. Then what are the indications? Those who are the cases who is in need of this one oxygen therapies, like RDS, respiratory distress syndrome in newborn, then pneumonia and bronchiolitis. Most of the cases, majority cases are pneumonia and bronchiolitis. They are in need of oxygen. Asthma, those who are having like asthma, also very different type of asthma, like some patients are like heredity also, they are getting, some are allergic also, all those cases we have to. Then transient tachypnea. What is transient tachypnea? Like those newborn babies, immediately after delivery, if they are not clearing the airway, that secretion which is causing to this very difficulty to get the oxygenation properly to the lungs. That's why patient will have this one tachypnea. Then birth asphyxia also very important. That is very common in pediatric and neonatal ICU. Apnea. What is apnea? Majority cases has been seen in newborn ICU that apnea they develop very easily. Those who are born low birth weight babies, apnea. Then cessation of breathing more than 20 seconds is called apnea. Then it has been seen very common, even those peripheries also, some babies delivered early, we should teach them that patient might have apnea, patient may not take breath properly, then gradually they will develop cyanosis, then immediate management, we have to, then we can, flicking in the legs also, immediate after birth, we can revive the patient. If this one, sometimes patient will not revive, then we need to go on oxygen therapy also in that cases. And seizures, very common, cardiac failure also common. Then in older children, stridor. What is stridor? Stridor means inspiratory sound is there. While patient is taking inspiration, there is some sound is there, that is stridor. Then cardiac, and some cardiac failure cases also, seizures also, coma, shock, preoperative or postoperative sedation, preoperative and postoperative sedation cases also, they will need oxygen. Then sign and symptom of hypoxia. Majority cases, they will develop apprehension, anxiety, restlessness. They might have behavior change also because they will feel weak, they will feel tired and decreased ability to concentrate what we are talking. And they will feel really well. And the dyspnea, fatigue, elevated blood pressure, increased pulse rate, increased respiratory rate. Majority cases, we see that patient will have increased respiratory rate. So those cases, suppose in a newborn, patient is having respiratory rate is 80, 90, then in that case, we have to be a matter of concern. Patient might be in need of oxygen, high oxygen therapy. That's why we have to be very careful. Then central cyanosis. Yesterday, somebody asked about, people asked about central cyanosis also. Generally, due to various cardiac problems and various disease conditions, the blue coloring of tongue and gums. Inability to drink or feed. Later on, patient will develop inability when gradually hypoxia, hypoxemia, and gradually they will develop inability to drink or feed. Then what is oxygen saturation? The main carrier of oxygen in blood is hemoglobin. Each hemoglobin molecule can carry 4 oxygen molecules. This one we did before when we are nursing, then we are reviewing again. Then oxygen content. The oxygen content of hemoglobin expressed as oxygen saturation, means how much oxygen is carrying by hemoglobin. Ratio between hemoglobin carrying oxygen and total hemoglobin. Then here, sources of oxygen. And before we are using these oxygen cylinders, all long years, even in our hospitals also, we are using these oxygen cylinders. Oxygen cylinder, how this one liquid, oxygen is produced in manufacturing plants by cooling air until it liquefies and then distilling the liquid to separate pure oxygen. In manufactured plant, what they will do, they will cooling the air until it liquefies, then distilling the liquid to separate pure oxygen, which is then passed through a liquid oxygen pump into the cylinders. Then we will carry to the hospital, then we use this different type of catheters to connect here. This one to everyone knows. Only this here, we are going to talk about concentrator. Actually, in our hospital setting also, nobody has used concentrators. Previously also classes we taught. Then in peripheries, this is using nowadays very common in peripheral hospitals, even in home setting, even we are using at our home now. This one, that oxygen concentrator. Here we are going to talk about how a oxygen concentrator works, what it is doing. Concentrator draws in air from the environment. It will draw the air from the environment. Usually contain 21% oxygen, 78% nitrogen, and 1% other gases. It extracts the nitrogen to leave almost pure oxygen. Means there will be almost pure oxygen, and inside it they will extract the nitrogen. And most concentrators supply oxygen at a concentration of 90 to 96%. They provide a safe, less expensive, reliable, cost-efficient source of oxygen. But only thing is that this concentrator, we need electricity. Those at home level, if suppose we don't have electricity, we don't have, then in that cases, it is a bit difficult to manage. Here is a concentrator. This is a switch off and on. There is oxygen. There is some setting also, timing we can sense. Here is the flow meter of, this is 5 till 5 liter here. In this is actually I'm using at home for my father. That's why I take photo. Then nebulization, and here we can give nebulization, and this is the oxygen. It will humidify. Then this is the air outlet. Inlet and outlet here. Then next, central pipe oxygen, and those this is central pipeline oxygen is very expensive. That's why in peripheries it is not available also. In larger hospital, oxygen is distributed through a copper pipe from central source. We have a central source outside, located outside the building. Then it will come to a copper pipes. It will come to these lines and will give to the administer to the patient. Here in central pipeline, this is the how we connect here, and we are connecting together with this one suction machine also. Then delivery methods, already previous class also, and later on also there is classes about high flow oxygen methods, and yesterday also talk about low flow oxygen devices, how we are using free flow. Here I won't talk in detail. Free flow oxygen, like what we are using, those patient central cyanosis and all, we put a mask nearby to the patient and lower limit of oxygen. Then nasal prongs also, this one we are using. This thing, we have to concern only one thing, that that sometimes while we oxygen, the nasal mucosa might be very dry and it might bleed also. Those things we have to concern. And high flow devices also, like inflating bags and masks, CPAP, high frequency nasal cannula, ventilators. There are different devices how we are using nasal prong masks. Now everywhere people are using. This is a non-revealing mask, and this is simple face mask. This is high flow nasal cannula. So that of this.
You can get the advantages.
This one. Here I'm going to talk about low flow device like nasal cannula. We are giving 1 to 6 liters, but in case of newborn, we have to be a bit careful. This 6 liter we should not administer, because the high chance of nasal mucosa dry and they will not able to tolerate. And here, what advantage? Safe and simple, easily tolerated, effective for low concentration, does not impede eating, interfere with eating and talking. Means when even those cases when we are giving by mask, suppose they are having food, in that case we can shift to nasal cannula so that they will be easy to eating. But we should be careful if patient SpO2 drops to a very low level. Then disadvantage, unable to use nasal, those who are having nasal obstruction, this nasal prong will not deliver proper oxygen. Drying of mucosa membranes. That's why those cases who are getting continuous oxygen, at least we should be concerned that we give some nasal drops to the patient. Like in our settings, we are giving some patients 4 hourly, 3 hourly accordingly. That the thing is that sometimes doctor may forget, we should remember them that we are not giving nasal drops. And this can dislodge easily, but in that cases, we should fix properly. May cause skin irritation or breakdown. Patient breathing pattern affects exec FiO2. Then oxygen conserving cannula. 8 till 8 liter we can give, indicate for long-term use of at home. We can use at home also, allow increased O2 concentration and lower flow. Cannula cannot be clean, and in that case, we are hardly using this. Then simple face masks also, 6 to 12 liter we are giving, they're very common. Majority patients, suppose we are giving nasal cannula not maintained, we go to simple face masks. Useful for short period of time, such as patient transportation and all also. Then this is advantage. Then what disadvantage? Contraindicated for patient who retain CO2 may induce feelings of like carbon dioxide toxicity is there. Those cases, suppose there is one outlet used to be there for simple face mask, this outlet is blocked by mucosa or something. In that cases, carbon dioxide toxicity is there. Partial rebreathing mask, then we can give till 15 liter. That is a good advantage. Those who are not maintaining by face mask channel, we are going to shift to those who are having severe distress cases, and then we are going to give 10 to 15 liter. Useful for short period delivery, increase FiO2 will increase easily, humidifies O2 and does not dry the mucous membrane, because we are using as a humidification also. Now, what is the disadvantage? Hot and confining may cause skin irritation, interfere with eating, drinking, and talking, and bag may twist or deflate. In case bag may twist or deflate, it is very dangerous. We have to be very careful. Then Venturi masks. Before we are using Venturi masks, but rarely we are using nowadays, that we can control the oxygen, then and specific amount of FiO2 patient will get. Masks and humidity may irritate skin. Disadvantage is here. Interfere with eating, drinking, and talking. High flow nasal cannula, adjustable FiO2. Then wide range of FiO2 can use on adults and children and infants. This we are using high flow nasal cannula nowadays. Then FiO2 depends on patient respiratory pattern and input flow. Then what is NRM? Provide one-way valve between mask and bag and exhalation ports. Here there is one-way valve, the oxygen will go and it will come, but when we exhale, it will not come back to the bag. That's very good. But here air outlet is there. If it is block or something, then carbon dioxide toxicity is there. That's why very important to remember, look at this while we're giving. FiO2 of 95% can be achieved with an oxygen flow rated 10 to 15 liter per minute.
I'll just inform something.
Yeah.
Those who are from the Negrin hospital and got dropped off in between and wanted to connect, please come to ICU classroom, okay, so that you can attend rest of the session. Those who are from Negrin's hospital, thank you, sorry.
It's okay. Then what are the advantages of like this non-rebreathing masks? What advantage I have talked already before also, highest possible FiO2 among low flow devices, then suitable for spontaneously breathing patient with severe hypoxia. Those cases, severe hypoxia, not maintaining with nasal prong, not maintaining in normal face mask, we are always going to shift to this non-rebreathing mask. This advantage, tight seal is required. Sometimes patient feel discomfort also. Then interfere with eating and drinking. Those patients who need to eat, and if we remove time, then patient will be suddenly drop down oxygen. Then malfunction can cause CO2 buildup, suffocation. Already I talked, if there is these holes are, if expiratory holes are closed, that carbon dioxide buildup is very. And if patient is getting, suppose we need 10 to 15 liters, if we are giving 4 or 5 liters, in that case also patient will build up carbon dioxide. That is very dangerous thing. We have to be very careful in that case. Then Another important trick for respiratory care of a patient, like those who are having COPD, asthmatic cases, what we use, like we instead, those patients going home, they are not staying at hospital anymore, then we can give them like inhalers. What is MDI? Metered dose inhaler. This one widely used nowadays. Delivery system for treatment of lung disease like asthma and COPD cases. This is effective for delivery of inhaled medication to the target site and has rapid onset of action. Here we are showing this one. This is even at home also. If our relative, someone is using, then we have to teach them how to use. This is the inhaler. This is a spacer. And those patients who are not able to take by mouthpiece, and we are using some inhaler mask is there according to the size of the mouth and nose. Then what are the components of MDI? MDI, here is a canister, and this one produce the aluminum or stainless steel there where the medicine will be remain there, where formulation will reside. Then metered valve, which allows the metered quantity of the formulation to be dispersed in each actuation. Means there will be a proper amount of this one metered valve will be there, so that we can give here as exact amount when what patient is needed. Then actuator or mouthpiece. Here is a mouthpiece or actuator which allows the patient to operate the device and directs the aerosol to the patient lung. It will go to the lung. And what is spacer? How will you use, what different type of spacer we are using? It is very important. Spacer resembles a cylindrical tube. Here we have shown already that a cylindrical tube creates space between side, mouth and medicine. This spacer, this is the spacer, it creates space between mouth and the medicine. How much space? Minimum 10 centimeter, at least there should be space between mouth and this one inhaler. Then spacer helps the medicine break into smaller droplets, which can move easier and deeper in the lung. Then from birth to 3 years old, small spacer with marks. Above 3 years, larger spacer without marks can be used. Those who can take without marks also, some patient we are giving. Now, what is spacer? Some valve or valve holding chamber. They are having valve holding chamber up to 100 ml small volume can be giving without valve. For small volume can be giving without valve. But those who are reading 100 to 35 ml or larger volume like 700 ml, we need to have valve. These are medium and some are large also volume. In the spacer, there are some medium volume and some like above 700 also for adult. Incorporate unidirectional valve at their mouthpiece. They have a unidirectional valve at the mouthpiece. That means that contents of that this one medicine will go to the mouthpiece. When we exhale, it will not come back to the inhaler. Distance of spacer and mouth should be 10 centimeter. It not should below 10 centimeter, or it may be a bit higher than 10 centimeter. Here we are showing like what are the different methods we are using that inhaler. We have to check the asthma care plan, how doctor is advising, how much to give, that's all. Then check the asthma plan, see when the medicine in your MDI. Then check the chamber. We have to observe the chamber, if anything, this one inside, if any crack or anything, this one air outlet, it is in good working condition or not. Then any foreign object also we have to observe. Then step 3, take the cap of the MDI, take the cap of the chamber, put the MDI into the rubber in the back of the, we have to fix nicely. Then shake the MDI and chamber at least 15 times so that it will be medicine will be dissolved. Then breathe out. Before giving this one, breathe out. Before giving the inhalation, the patient need to be breathed out normally. Then put the chamber mouthpiece into your mouth. Close your lip tightly around the mouthpiece so that there will be no leaking. Then push the MDI down so 1 puff of medicine is sprayed into the chamber. After this one puff, we'll tell them to take slow deep breath and hold for 10 seconds. Minimum 10 seconds, patient need to be hold the breath so that medicine will go to the target of the lungs. Then you should not hear or whistle. After that, we'll tell them to breathe out normally after 10 seconds. Then step 8, what we'll do, if you are supposed to take 2 puffs, the medicine, and wait for 1 minute, then we'll repeat in the same way, like we'll say, we'll breathe out, and we'll take the mouthpiece in your mouth and push the MDI puff. Then after taking the next on also, we'll hold the breath for 10 seconds, and we'll tell them to breathe out after 10 seconds. Then what we have to be take care of this one canister and taking care is very important. The chamber, keep your chamber clean. Chamber should be washed once a week. Wash your chamber in a clean pot or bowl of warm water with this dishwashing soap. Do not rinse, let it air dry. Never use a towel or dry your chamber. It has chance of breaking. That's why if the chamber is cracked or broken, it needs to be replaced. Then in the same way, like those patients who are not able to take by mouth, they need a mask. Here we are going, check the silence, mark airplane, same only check the chamber. We'll connect together. This is a mask, this is the spacer, this is the canister. Then sit your child on lap. Those who are not able to cooperate, we can keep the small batsa, we can make and keep in our lap also. Then place the marks of your child face and make sure that it's sealed over the mouth and nose. Because while we are giving a mask, it should feel like nose and mouth so that there will be no air leaking and patient will get the medication into the target site. Then push down the MDI. So 1 puff of medicine is sprayed into the chamber. Same way, we'll tell them to take, we'll keep for keep the marks placed by anchoring your hand under the child's chin and until your child breathe in and out 6 times. We'll hold the marks. Here, patient will not know, not small batsa. That's why we have to keep them at least 6 times. Patient will taking breath with the marks only, so that patient will get the remaining particles of medicines to the target site. Then step 8, 2 puff of medicine have been prescribed with 1 minute. Then repeat step 4, 5, and 7. Means same thing only. We'll put connected together. We'll make sitting position. Second puff also will give likewise. Then 9, same thing only. The cleaning process is same. Like we have to wash once in a week. We should not dry with towel or it may have chance to broken. We should soap with dishwashing soap only. Normal water only or normal lukewarm water only. Then key points to remember while using inhaler. What things the drugs used are beta-adrenergics like salbutamol, terbutaline, steroids, atropine derivatives, and chromoglycate sodiums. The capacity of spacer, that is very important thing. That capacity of inhaler is 150 ml for infant and 750 ml for children for age of 4 years or more. Means for infant, we are using only 150 ml, means smaller size. That's all. Thank you.
Thank you. Thank you. I think within a short period of time, you have covered 3-4 topics. Thank you so much, Sunita sister, for detailed information. Now I will request Kamala madam to, say something about this topic. Over to you, ma'am.
Thank you, Nanuka, for giving the opportunity, and thank you, Sister Sunita, also. In a very short period, we have covered a very vast topic, which is not possible to complete within 1 hour. So, really, we are doing so much hard work so that we fulfill the requirements as well as a refreshing session for the the whole nurses we are doing. So I think there is no specific point to add up because Sister Sunita have already covered up all the respiratory, all the methods of the respiratory, how we will be delivering, how much amount of oxygen it is going to deliver, and what is the concentration of the oxygen amount, the percentage, everything they have covered up. They have covered up the postural drainage system, and then chest physios they have covered, as well as the very important one, that non-rebreather masks. So that is also a very effective method of oxygen therapy, as well as sister have mentioned about the MDI along with the spatial, how we are going to use, and even her own experience with that. She brought up the oxygen concentrator and she have shown us, and I think it will be very much effective to our whole nursing fraternity which are participating here. So apart from this, I think there is not that much point to add up also. So everything she have covered up.
Thank you so much. Yes, within a short period of time, Sister Sunita have covered everything. And actually, in migraines, we don't much use a concentrator. We don't use actually concentrator. So I request any participants, who are using this concentrator very frequently, and if you are facing any challenges, or even if you have good practices, you can share in the platform so that other fellow can also learn from you. Even we can learn from you. It's not only the ma'am, it's not only the learning from us. Let's learn each other.
We only teach to others. It's a platform where we can share our informations and everything to each other.
Yes, I think it is the great platform, because where the 1,000 nurses are coming together and working together. That is a great opportunity. Otherwise, this amount of nurses we will not get, and we will not meet also. So I request nurses, those who are here, can you please share your experience, or you can share your good practices which we have missed also. So you can share. And even I request to write down your queries in the chat box. Today, I think Sister has explained nicely. I have not seen single questions here in the chat box. They are just asking about the post-test and you can write down your queries here, and then yes, we have given the post-test. Those who have submitted post-test and feedback, thank you so much. No need to mention here that you have submitted pre-test, post-test. Okay. I've seen one question is, is there any difference between the quality of oxygen through cylinder or concentrator, which is more recommended, and for how long we can use a concentrate machines for our patients? Actually, I think it's about the oxygens, because I think in the oxygens, either in the cylinders or in the concentrator, that amount is almost same. Concentrator, we are especially recommending to those areas where you are not, especially we have used a lot during a COVID time, because there we are the filling of the oxygen cylinders and all, it was a problems. And oxygen concentrator, they are using just our atmospheric air. You don't have to fill. They are just using this concentrator machine. They use just atmospheric air, and they will just, give the oxygens from there. So it's easy to use, but it's not like which one is the best one.
Affordable to everyone. The concentrator is also.
Yes. So I think anything else you want to add here, or another question is asked, like MDI with a spacer indicated for neonates?
Neonate not using. We are not using neonates, actually. Till now, we are not using this one, MDI for this one, neonates.
Because I think my sister has nicely explained, like when we are using this MDI spacer, you need to give a certain instruction. They need to inhale and they need to hold a breath, kind of thing. She has explained the procedure nice. But if with the neonate, then they are not able to follow the instruction. Kamla ma'am, you want to add anything?
Yeah, that's what you are saying is the correct only. The instruction which we are giving to the this young children and older children, that cannot be followed to the neonates.
Yes, and one more thing is important. I just wanted to add, when you are using a spacers, please check it nicely. At least they are telling at least 15 times you need to check, and then also check whether any kind of foreign materials, anything foreign body is there or not, because sometimes we'll miss, and then they in hurry we will. It's a regular user, because people who are using a spacer, they use it continuously. So sometimes they will not give that much attentions whether it's okay or not, or any foreign body is there or not. And if it's there, and if they are inhaling, if they are taking a deep breath, then it may, cause a problem as kind of aspiration. So please check that one properly. Okay, so anyone who wants to share any experience? I think many of your kids may be using a spacers, or many of you have used a concentrator during a COVID times, or maybe many of you have a good experience. I think I encourage nurses to speak. I know we are not speaking much, but even if you are writing down in the chat box, I'll just read it out. Okay? Any of your experience or any things, best practices that you are doing, even if you will write down, even if you don't want to speak, then I will just read it out. I have seen a hand raised by Venistar. Venistar says you want to speak. If you want to speak, we'll give access to talk. You can write in the chat box. If you want to speak, yes, then I'll give access to talk. We can still wait for 3-4 minutes because we are on time only. Thank you, those who have submitted the post-test, pre-test, and feedback. Thank you so much. Any queries? Can I fill the post-test again? You can try. I don't think twice you can do. Same person, I don't think you can submit it twice, but you can try. Very wonderful session. Thank you. Ma'am, does oxygen cylinder have expiry date? Oxygen cylinder have a cylinder. You want to say something? Cylinder, I have never heard about. Kamala ma'am, do you have any idea that it's cylinder have expiry date? Or any of you want to answer in the chat box also? You can write.
I have seen the question.
Yes.
Cylinders. So if you talk about this normal things, so you have seen in the clinical area also, when the cylinders, we need to refill the oxygen. So like that only we are doing, but in up to now, me also, I didn't heard that in the clinical area.
So actually for us, we are using every day. Then we need every day new cylinders only. That's why we didn't wait for so long. Maybe for that also we don't have knowledge.
Me also, because during my entire career time, I have not heard about expiry date of cylinder. But yes, that feeling they will, I think, within 15 days, in a month, as per your consumption, they will do the refilling continuously. Or any of you have a better answer, you can write down in the chat box. Can we use a tap water in oxygens? No?
No. We cannot use tap water. Either this one, we use the distilled water.
Distilled water. Sorry, I think you are talking about humidifications.
Yeah, that is your.
For humidifier, I think they're asking.
Yes. Oh, WhatsApp link group, I have already shared in the chat box. Anyone, how many times we can nebulizers for a baby below 1 year in a day? The baby, if it's less than 1 year, how many times?
The doctor will advise according to the severity of the condition. Even there's a newborn baby also, we are giving nebulization 6 hourly, 4 hourly, like that. In severe condition, we are giving 2 hourly also, like Estalin or adrenaline. And then later on, we used to decrease. Suppose we are starting now 2 hourly. Gradually patient is okay, means no retext or no distress, then we are going to make 6 hourly, 4 hourly, like that, according to the patient condition.
Okay. And does using nebulizations for a long period of time affect the child? Kamala ma'am, you want to answer this one?
Yes.
You want to answer?
Okay.
Yes.
Right now.
Does using a nebulizations for a long period of time affect the child?
Yeah, definitely it will affect the child.
Okay, Sunita says you want to.
Yes, definitely it is steroid we are giving. If we are giving either normal saline or that is okay. But in case we are giving some steroids to continuously, that is harmful for the baby.
I think it is suctioning.
Any
and all.
medication is harmful. Even oxygen also, like using as a drug only, it is also harmful if we give for long.
Yes, yes. I think ET suctioning and all, I think we will discuss later. This is not in this class. Tap water is tap water is this thing. We can't drink a tap water. No? There is, can we use a tap water for humidification?
We use
Oh,
but it's still
that one the tap water is not clean water, means there might be some organisms, there might be some dirty things, then it will go to the lungs while we are giving in humidifier. Because oxygen will go through that humidification line. That's why we have to be careful about this. Patient may got infection through this one also.
Okay, I think you got the answer. So instead of tap water, we prefer this distilled water. Okay. Can nebulizations given for severe cough when chest is clear, no crepes or no wheeze or no respiratory problem?
Actually, if like that, in that cases, patient might have cough without secretion, without thick secretion. If patient is having cough, then in that case, no need of nebulization. Medication will do, like antibiotic therapy and all those pneumonia cases, and even like oral medication will give more.
I think, can we use a 3% nebulizations for our children?
Yes, we are using.
We are using.
Yeah, that is very common. We are using 3% nebulization in our department.
What about filter water? They are saying instead of if there is no tap water, no.
Yes, no water, filter water.
Filter, I think filter water is a good, but again,
we prefer distilled water only. Distilled water we
I think filter water is much better as compared to tap water, but we will not say. Why, ma'am, some patients, when we give a nebulizer, they used to complain of headache. Kamala sister, do you have any idea?
We rarely got, because in pediatric cases, no?
Yeah, here we are dealing with a pediatric case and we don't get this kind of complaint from the baby, kids.
But in the adults also, to my experience, though, I never met that patient that are complaining of a headache.
Okay. I think it's depend upon again the patients, no? Sometimes
that's why for parents, we have to explain to the patient that whereas adult patient they will feel if we didn't explain them what we are going to do, they will fear of oxygen also sometimes. That's why a patient may complain of headache also. That is like fear factor might be also.
I think maybe.
And suppose in case oxygen level is okay, patient is just giving nebulization, that he might get over oxygen. No?
We have mentioned that they may have feeling of closeness, that claustrophobia also, they may have the feeling. So because of that, it might be.
Okay. And then one is like, ma'am, is patients can be used for 2-3 years. I didn't get.
Yeah. No, but at least we are not using for newborn babies, and 2-3 years maybe we are using only.
Okay. In which condition adrenaline nebulization is used, ma'am? Kamalama, you want the answers? In
Pardon
which
the question?
In which conditions adrenaline nebulization is used?
If there is thick secretions are there, to moisten the secretions according to the need of the patient. So we used to give the adrenaline nebulization.
CB, I didn't understood what you want to say. I don't understand. Can we give the nebulization for a child with a severe chest? Okay, we have already answered. Oh. Can we give the nebulization for a child with a severe chest fullness with a high-grade fever?
In that case, we have to manage the fever also together. Chest fullness.
Sis, you want to talk? What do you mean by chest fullness? But you can write here so that I can read? Okay, and then Fira have shared her experience that very frequent use of nebulizer may also lead to tremor, which she have already
We should not give very
encountered.
frequent nebulization actually. That one, suppose we are giving now too early. Some cases we are giving like immediately 3 doses of nebulization within 20 minute interval. In that case, what is the meaning here frequent nebulization? We are not giving frequently actually. Majority cases we are having time period.
Actually, as
giving.
per the doctors, this
Yeah.
I think this
Prescription.
okay, like wheezing and all. So she wanted to say like full this means
Wheezing to it, we have to
Wheezing
give,
and
we can give, only in that case we have to manage fever at the same time. Wheezing means the patient is in need of having secretions in the lower airway, patient having expiratory sound. That means wheezing is the expiratory sound. That might be having thick secretion or some other reasons that in that case, we have to manage at the same time fever also. We are giving some fever medication and you can give nebulization, it won't happen.
Okay, thank you. I think I have not seen any more questions here. Actually, I request any of the participant can share your experience of using all those things we have actually used. Even if you don't want to talk, you can write down in the chat box. I can read. If not, then I think there is no more questions here. And we are also on time. So I think if nobody wants to share your experience, okay, then I think we have answers.